Welcome to the Critical Care Obstetrics podcast. I'm Dr. Stephanie Martin, and I'm here with my partner, Dr. Suzanne McMurtry Baird, our nursing director at Clinical Concepts, and we have an incredible special guest, Dr. Karin Fox, who I'm going to be introducing in a moment. But first, we want to remind you guys about our Patreon community. We release the podcast every other week, and if you want more of this, on the alternating weeks, we release new webinars, recordings, podcast type things, educational offerings, and a once a month live webinar where you can interact directly with us. That's at patreon.com/CCOB. We hope to see you guys there and help support us through that. And then go to the Critical Care Obstetrics Academy. We've got some new offerings, including our diabetic ketoacidosis in pregnancy offering, where we've got an online course, we've got downloadable algorithm and checklists, and we've got a whole simulation toolkit. So go check that out at the website, clinicalconceptsinob.com, and see what we have to offer. But now on to our incredible guest, Dr. Karin Fox. Dr. Fox is a maternal-fetal medicine specialist who I met many years ago when I was the division director at Baylor in Houston. And I remember bringing Dr. Fox in for a job interview very early in my time there when I was building the division, and I could not believe my lucky stars. Like, it was like the perfect MFM, just walked in the door ready to be hired. And I'm like, you're hired. I mean, the interview wasn't even over. And I was like, you're hired. You're done. You're part of this team. So I felt like she fell into my lap and really added huge amounts to the team while I was there, and has just continued to do incredible things in the years since. Currently, she's in Galveston at UTMB, where she did her residency and fellowship training. She specializes in all the stuff that terrifies most physicians, much less maternal-fetal medicine physicians. And today we're going to be focusing really on Placenta Accreta Spectrum disorder management, because she is truly a pioneer in this field. She will be very humble about it, but she is really leading the way and heavily published, tremendous clinical experience, leadership of teams, training the next generation in how to manage this complication. She's involved internationally in many organizations that deal with PAS, Placenta Accreta Spectrum, including the International Society for PAS, the Pan American Society. She's part of the coding committee at SMFM. She's journal editor. She's authored over 100 peer-reviewed publications. And she is an incredible athlete. She's a veteran. She's a mom and a fun person. So,
and I want to say I got to work with her too. So
yes, that's right.
I remember her when she was just starting at Texas Children's, and she's a lovely person to work with. Such a team spirit, and I always appreciated working with you.
Another nursing advocate. Definitely
yes.
a nurse,
yes.
a friend to nurses, for sure.
And in fact, she just lectured at A1 convention this year on PAS, and had a great audience. And she was just saying, they were coming up to her afterwards saying, oh my gosh, I came to your lecture, and they will fangirl over you at A1. So that's the really fun thing. So I'm so thankful for that you shared your knowledge with the nurses there and continue to do so. So,
did I leave anything out, Karin?
Oh my gosh, no, you're making me feel tired though. I mean,
makes us choosing. Yeah, it makes me feel tired.
I actually am post-call. So if I say something that sounds weird, it's probably because I am a little tired. I've got my coffee in one hand, my water in the other hand.
Oh.
And, but I'm really excited. I'm really excited to be here. And I was also going to introduce the fact that Stephanie Martin is the person who gave me my first real attending job after I finished my training. And so I'm forever grateful. And it I don't know, it kind of melted my heart a little bit when you said I'm a pioneer in this field, because I just feel like I'm one carrying the torch a little bit and trying to learn alongside a lot of other people. And Dr. Martin, you were certainly one of those people who was doing these Accreta cases when I got there. And I just said, yeah, I'm interested. And you and Mike Belfort said, then you see all the patients, you come to every case, you learn what you need to do. And I showed up, and I
That
think
you did.
that might have made all the difference. But anyway, and Suzanne too, I have to say, you know, we can't do what we do in high risk pregnancy care in general, but especially with the most complex cases without a multidisciplinary team. And I think a lot of the times when we think about who's on the team, a lot of our publications talk about the maternal fetal medicine specialist, the gynecologic oncologist, the anesthesiologist, the blood bank, and we forget to mention the nursing staff,
Yes.
which I mean, truly like that. And I even said this at A1 that was a horrible oversight, even in our publications that I helped co-author, that we cannot do this without our nursing team because, you know, oftentimes it's our nurses who are the first people to see somebody in triage when they stop in. They ask some of the questions that help us, you know, alert us that, hey, this patient might have some risk factors for something going on. Or they're the ones who take that first phone call. Hey, I'm trying to get to see you as a patient. How do I connect with the doctor or the team? And so the role that nurses play is incredible, not to mention the fact that the bedside nurses are looking at that patient saying, hey, this patient looks different. Like
Yeah.
I've been here all day. This is a change. Or, hey, I'm worried. I need you to come and see this patient, please, with me.
Yeah.
And so I just think sometimes like what life would be like if I have colleagues who, God forbid, are going through trying to take care of patients during a nursing strike. So more power to all the people who are experiencing that now. More power to them.
You'll never understand how valuable your nurses are until they're not
Right.
there.
So I gotta say, I think about how it would be if we didn't have all the people helping us do what we do.
Mm-hmm.
Well, but that's why we all made a great team, is because we had that mutual respect and everybody knew their role, and that everybody had a great impact on the way we were going to care for our patients. And I remember working with you and Stephanie when we were developing that program at Texas Children's, and putting together these forms that the nurses would use, and the checklist, and the things that we want, how we wanted to care for those patients, not only antepartum, but intrapartum, and during the surgical procedure and postpartum. It truly was a team commitment. And we did great work and in developing that into such a robust program that I was just surprised at how many people we had coming there from all over the place. So.
And I guess I think that's one of the things that people don't really understand from my perspective, and I'd want to hear your perspective too, is that managing placenta accreta spectrum is not just a surgery. You really do have to have a program. It's like saying, I treat cancer. It's not about the oncologist. It's about the program that takes care of the patient because they're so high risk. And, you know, we kind of built one from the ground up years ago. And, you know, when we go talk to people, when we go out to facilities, I think that's a common misconception, is that people think that just because I personally, as a physician, am comfortable doing this surgery, then everybody around me should support me doing this surgery. Like, what's your perspective on that?
I love that. Well, and I've got a lot of thoughts. I have to let me get them in order.
So many thoughts.
But no, I absolutely agree. And you can hear this from patients for sure. You can hear it from, and we're still learning how to do this better, quite frankly. That's why I'm so involved in these national and international groups. And we partner with the National Accreta Foundation, which is a patient-centered group. It was started by former patients who were survivors of placenta accreta spectrum and their families. And so we actually collaborate quite closely with them as well. And we continue to learn from one another. But it really is a system of care. It is not just like a normal pregnancy. And again, there's enough. A part of it even starts with just knowledge. So I've heard from patients that they went to a doctor, a very trusted OBGYN, or somebody who they've seen for a long time, and they said, "Oh, I think I've seen one of these in my career." And that's scary to hear.
Yes.
Yeah.
It's helpful to hear from their doctor, "Oh, but I know who to refer you to, and here you need to go see this person." Even then, still, I sometimes get phone calls, believe it or not, through these societies with families asking, where's the best place to go? And then I have to say, well, it's not just one best place, but you need to go to a place that has this, 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 and this these are some centers that are near you that work with us in our organizations that you should check out. Or, oh, you've got appointments with these groups. Those are people who are really doing the work like we are. While we want to build teams, we want to have a really robust place for people to get good comprehensive care. I'm also really of the opinion that I do not want my daughters or my son living in a world where they can only go to one center to get good care.
Right.
It needs to be available to people. So that's part of it. So building the system is important. And what I'm seeing too is when there are some folks who are starting to build teams in other hospitals and other centers, and they're finding the same struggle that, it can't just be me. I need the support. How am I going to work my call schedule so that I can actually come in and do this and help support my division? Who else do I need on my team? How do I talk to the C-suite about why this is important? And it's not just a cost, but it's an investment, so there's a lot of moving pieces that people have to really work through. And because we've seen that really team-based need, the niche, the need to really organize people together to get things not just functional, but sustainable.
Right.
That's going to be a big part of our focus of our national meeting this year. That's coming up in October. So we're trying to help, those of us who've kind of walked that road before, we're trying to collaborate, talk to others who are building programs, learn from one another when it comes to a program that's already in place, and grow.
Well, and, for those who may not be aware, this is based in outcomes. Like, outcomes are worse if you have your hysterectomy, your cesarean hysterectomy performed for Accreta in a place that is not routinely doing Accretas and that does not have a program or a team, however that happens to be defined. So outcomes are better. Can you speak to that? Like, what does that look like if you're, someplace where they're less experienced compared to more experienced? Why does it matter?
Yeah, I think there's a bunch of reasons, actually. One is, when we're talking about placenta accreta spectrum, the risks really are surgical difficulty. It's a complex surgery. And I know we said it's not just about the surgery, but it is a complex surgery.
Yes, it is complex.
You can make just a 1 millimeter or 2 millimeter error in where you place an instrument and have massive hemorrhage start.
I used to joke to people, don't even look at the placenta.
Yeah.
Not much less touch it. If you look at it sideways, it's going to bleed.
Don't sneeze wrong. But it's like turning on the faucet in your sink, and that's how fast the bleeding can run.
Yes.
And so we need to have good knowledge, really clear communication, and so people who know what they're doing. The other risk is if it's a center where maybe they're not used to seeing this a lot or don't recognize it on ultrasound. So we know outcomes are worse too if it's diagnosed only when we first go to do the delivery. Like, if we can detect it beforehand and be prepared and have everything ready to go, it saves time. We've got the resources. We gather the people who need to be in the room, and that helps the outcomes as well.
So for the nurses that are listening, okay, and for the docs too, for that matter, if you have a previa with a prior scar on the uterus, most commonly a cesarean, it's an Accreta until proven otherwise and needs to be seen by someone who knows what they're looking at, period. And that can happen at any point, but that needs to happen. So if they've made it to the OR for their repeat C-section and nobody has specifically excluded that, that's a problem, a potential problem. So you don't have to know how to look for it. You just have to know who's at risk for it to send them out.
Yeah. And I want to reinforce that previa is the biggest risk factor. We talk about C-section being the biggest risk factor, but it's the biggest semi-modifiable risk factor. We can't get rid of all C-sections. Like, I would not have had my kids without C-sections. That just would, one of us would have been in peril. But we can look for previa and we can plan.
Yes.
So that's so important. And for the other docs and the nurses out there, I'm also going to throw out there, even under the best of eyes with the best technology, we can't see all accretas. Like, there's a very small false negative rate. Maybe it's in a cornu or on a scar from Asherman syndrome. So we have to have a high index of suspicion and know what to do if we find it when we're in the ER. So that's where experience comes in as well. Like if I do have that surprise case, or maybe, for example, somebody sends in a case that's like, it's a maybe Accreta. I don't know. I don't feel comfortable delivering in my small community hospital. I have only seen one or two of these in my whole career. I'm not sure. And I deliver and I say, well, I've had a lot of experience. We'll be happy to take care of this patient. We can have all the resources nearby. Two things might happen. The placenta may just deliver and it's fine. And I can pause and say, wait, we don't need to go down a route where we're doing more surgery or a bigger intervention like a big hysterectomy if we don't need to. On the flip side, if it's maybe, we think maybe it's just going to be a tough C-section, but the placenta is going to deliver, but nope. Oh, yep. It's an Accreta. Guess what? We've got the resources and we have protocols in place for the surprise cases as well.
So I feel like there's kind of two things that I want to highlight here. And Suzanne, I want you to pipe in too, because we've got knowing ahead of time that we've got an Accreta. Yeah. And when we say Accreta, guys, we're talking about everything from a tiny little area of invasion to placenta metastasizing outside the uterus into other blood vessels. Like I call it metastasizing because that's what it looks like. It's crazy. So we're just using a bucket term. So don't get too, we clinically don't get that caught up on what level layer it is because you don't always know.
Yeah, you don't always know until you don't always know.
So, we want to know if it goes beyond the uterus, but Accreta is a bucket term. So we've got the known Accreta. We're doing an ultrasound. We've got a patient at risk. We're pretty darn sure that that's what we're dealing with. Sometimes we're wrong, but we're making the plans as if that's what we're dealing with. And then we have oh my gosh, this is not normal. I don't know what it is, but it might, something needs to change. Kind of two different scenarios. So can you speak to, if you know that you've got an Accreta, if you're not a center, what needs to happen?
Oh yeah. I think that's so important. First of all, it's really good to know who your friends are. So who are the centers nearby? That's really important. In fact, at some point in time, I might have to return a call here, but who can you call? Hey, I have this lady. I see this. And I've received those calls sometimes beyond where you might think. We always like the call early, but sometimes it's like, hey, this patient is 39 weeks. They were going to be delivered by another group. She happened to drop in. I did a scan. This placenta looks like a nightmare. I can't deliver her here. Okay. Well, it's later than we would normally deliver somebody with a Placenta Accreta Spectrum, but send her our way and we'll take care of her. Or sometimes it's just like, hey, I need a second set of eyes on. Yes. I don't know what I'm looking at. I think this might be an Accreta or not. She's had 3 C-sections. Can you tell me if you think it's safe for me to deliver her here, or does she need to go there? And that's where we can do the imaging. We can, go from there. If it is one of those cases, this is really important too, where you are in the OR or you deliver and you recognize this placenta cannot come out. Or when I open the abdomen, wow, this looks messy. I think this might be an Accreta. You have the option, if the patient is stable, to stop.
Yes.
And pause.
Thank you for saying that.
Yeah. And there's a really nice algorithm that Brett Einerson from Utah and Danny Carusi from Boston both put together that illustrates this really nicely. So you pause and then you assess. Is the baby stable? Is mom stable? If that is the case, just close the abdomen and then transport the patient.
I always tell people, just because you're looking at a uterus doesn't mean you have to cut it.
Exactly. Or maybe you do. Yeah. Maybe you do have to deliver that baby because the baby's having decels or something's happening. So you want to make sure you deliver away from the placenta. Do not cut through the placenta. It will bleed. So you want to deliver maybe at the fundus. Maybe far, high away from that uterus. And sometimes I've even had twins where we had to kind of map out with an ultrasound probe. With a sterile cover on it, and you find, okay, this is the clean area. Maybe it's on the backside of the uterus, but you deliver, you close up the uterus, and maybe you have to send the patient with blood, but make sure, again, are they stable enough to get on a helicopter, get in that ambulance? And then, of course, you when you do a transfer, you call the transfer center at your hospital. They connect on a recorded line to the receiving hospital. You talk about the clinical scenario, but that gets time for your center that deals with us all the time to assemble their team. And so there have definitely been times when we've just waited for the patient to arrive by helicopter, for example. And we take her right to the OR.
Suzanne,
Go
from
ahead.
a nursing perspective, like, what are your thoughts on that?
Well,
yes.
Well, I'm going to go back just a few minutes and talk about what you said originally, and it kind of ties into what you're saying right now. And that is, number one, it can't be one person dependent on any team, and that it also includes your level 1, level 2 maternal care centers that also may or may not have a regionalized program in their state on where to transport patients to.
Yep.
They don't have the resources to do this in their facilities, and so they have to have a plan for when that patient has an unknown accreta and shows up either in their triage, their ED, or maybe it is so far to the tertiary care center or the center where she is going to deliver that they show up in the OB service at any hospital in between, right? So everybody has to have a plan, and it can't be person dependent. That person goes on vacation. That person, is asked to sleep, go home, and have a life, and that's so important when you're setting up your plan. And that's one thing that we did, and I wanted to make sure, because any plan that you have for these patients coming in from a nursing perspective can't survive based upon one nurse, one doc, one anesthesiologist, one OR team, because they're not going to always be available. So the plan has to be set in place, and you have to have practiced it as the team. So, and you have to have all the other things that guide nursing care, and that is those things like a checklist, and that is worked out with physicians like you two, that to say, what do you want to see? How do you want me to care for this patient when they're either antepartum or in the OR or prior to the OR? And you have to work it out with anesthesiologists too. They're a big part of the team. I thought maybe, Karin, you could go over who are all the team members that you see mostly in some of these centers that do these routinely, so that the listener can understand, do we even have the resources at our hospital to do this? Because just because you're a level 3 or level 4 maternal care center doesn't mean that you're going to be doing these either, right?
Yeah, that's a really good point. Well, and it varies. I mean, that is the trick. It varies widely. And especially because I've engaged with the international community, like, it's not even just some states. There are some countries that don't even have a center within their country, let alone, so some of the burden does fall on, maybe, I don't want to say a suboptimal team. That isn't quite the right word, but teams that if areas had better resources, where the outcomes might be better.
Right.
But there is this burden. So the makeup may vary a little bit based on specialty, but really what you need is somebody who knows how to identify, do the imaging and identify the accreta early. So your maternal-fetal medicine specialists are really keen radiologists who've seen a lot of accreta, either on ultrasound or MRI. Maybe it's a OBGYN who's really good at ultrasound. Those folks are important. Then we've got our surgical team, and that might be made up of a maternal-fetal medicine specialist, again, a general OBGYN who really loves those kinds of surgeries. It might be a gynecologic oncologist. A lot of teams have an oncologist there because they do more extensive surgery in the pelvis for cancer. Although I will say that a placenta that has really kind of extended out and gotten scarred and had some vessels grow that look really scary is not the same as a solid tumor. So you need somebody who still respects the placenta as a really blood-filled organ. And
really blood-filled organ.
Yes. Transplant surgeons are on some teams. Trauma surgeons, like the team that I work on now, trauma surgeon is in our first call group. And no, we are a group of MFMs who all do the surgeries, but we always notify our trauma team so that if we do start needing friends to come and help us, they are readily available. Urology, also very common. Sometimes we will put stents or temporary ureteral catheters in the ureters to help protect them because the placenta can kind of extend over them. And They're very close to the uterus, so they're a little bit more at risk for injury if you can't dissect them out easily. And it helps you feel and move the ureter. It doesn't necessarily mean you won't have an injury to the bladder or to the ureter, but you can identify it quicker.
Speak about the
gynecologist.
anesthesiology part of it.
Anesthesiology, 100%. We need those folks. So without good anesthesia, because these surgeries, if we're doing, I'm going to drift a little bit, but there are a few cases where we don't have to do that hysterectomy. I'll talk more about that in a little bit. But oftentimes, if you've got a very extensive, very low lateral process, you need to plan to do a hysterectomy. So you deliver the baby. It takes a little longer. We've learned that mothers can stay awake with a combined spinal epidural and do very well. But when we start moving things out of the way to do that hysterectomy, it becomes very uncomfortable. We don't want patients in pain. It can be distressing. And if we do need to get an emergent airway when somebody's bleeding heavily, then it becomes a more emergent and more difficult airway, even than just pregnancy alone.
Right.
So oftentimes teams will either have, combined spinal epidural with a pretty early conversion to general anesthesia for the hysterectomy portion. So we need people who have really good skills. Getting additional lines if bleeding starts. We need to make sure that they can get a very large, like 14 gauge, 16 gauge line to give a rapid transfusion, or a central line is oftentimes used to give very high volumes of fluid when necessary. And an arterial line, also very helpful. Which brings me to the next team of people who are really essential, blood bank. So our transfusion medicine friends, really helpful, making sure we have, if we're going to transfuse, that we have the safest blood possible to transfuse. And I say if because we don't always need to, but much more often than we would for just a routine C-section. And sometimes massive transfusion. So we need to have the ability to get not just a little bit of blood, but a lot of blood and fast. I can tell you some of the biggest cases that I've been in, we've used well over 90 units of product.
I was going to ask you about,
that's not the goal, but that's,
but that's what can happen. And I think people who have not seen obstetric hemorrhage don't necessarily understand what we're talking about. And it's one thing to say 500 to 700 cc's a minute. That doesn't mean a whole lot to people until you hear the bleeding. It's literally pouring on the floor and it's splashing and you're soaked, and it can be quite chaotic. And I mean, we've spoken to other folks about this as well, but probably as closely aligned to a trauma experience than any other like specialty or service line in the hospital. You agree?
Agreed. 100%. I mean, and I'm going to even take that a step further. It is as much like a trauma as any trauma, having a gunshot wound both physically and emotionally. So that's the other aspect. So, so transfusion medicine specialists, perfusionists who can, work the rapid infuser if we're going to, or cell saver if we're going to do cell salvage. Which
are you still seeing that used a lot? I know we were using it.
Yeah, it depends. So for a while at Baylor, we were using it very often, and then we weren't using it so much because our blood loss had gone down. So we might have it ready for the big cases, but we wouldn't use it universally. It kind of became an issue of, well, either we need more or we don't need it at all. We use it at UTMB, but it's because it's a nice small machine. Those cell savers have become very compact. They even have some that are available for transport EMS services, believe it or not.
Wow.
They're compact enough to go on an ambulance. So we actually do use it, but with all the precautions of, making sure we switch the suction after the amniotic fluid has been used. Or if we're putting product in that's hemostatic, then we're not sectioning that back out again. So, because again, there's a little bit of a component of, if we don't have to transfuse another unit and we can give mom some of her own red blood cells back, that's some salvage that we are willing to try to work with. Yeah.
A couple things. I want to talk about the patient and the emotional side of this, both for the team and everything. But before we get to that, talking about the technical challenges of this procedure, really can't be underestimated. And it's very challenging to train people how to, this is not a resident case, but there's a role for training within this. And you have really been creative in developing ways to train people. So you do train people and you have trained people. And so can you speak to, from your perspective, this is not a see one, do one, teach one. This is, and one wrong move in this surgery could literally lead to massive transfusion or loss of life. There's no room to mess around here. So how do you train the next generation? Like, how do you get people to be good surgeons in such a high stakes situation? Like, I know you've created something, and I'm getting at that, but I want you to just talk about this.
I'll talk a little bit about the other broader aspects, even without like simulation and other training tools. But I think it starts with just good practice. And I'll tell you, I think right now the residents who I work with, I love them dearly, but I think sometimes they're like, oh my gosh, here comes Dr. Fox again with another, like, please tie your knots this way discussion. But it starts with really good surgical habits when it's easy.
Yes.
So, and it's so much easier to train somebody to do something well the first time than to have to untrain bad habits.
Well, and I think to expand on that, you're 100% correct. And the other part is that when they see really good surgeons like you operate, and then it gets real easy to think, I can do that too.
Do this.
Because you're making it look easy. It's like when I'm watching, ice skating at the Olympics, I'm like, big deal. She didn't do 4. Like, what's the matter with her? Like it looks so easy, but it's incredibly difficult.
I'm not thinking that at all. But.
No, but you're right though. So it looks like, well, here's the thing. If I see somebody really savvy do something that looks easy, and then I use a less refined skill that I have that's similar, and I'm confident. So I can be confident, but not competent. And that's a dangerous combination.
This. Okay, right? Say that again. That's fantastic.
I can be confident and not competent.
Yes.
And that's a dangerous combination.
So good. That's so true.
I even have to fight that in myself sometimes, like to like remember. And I joke about this with other we call it accretologists now, but like for those of us who do this work, the time to like not have a little bit of fear of the accreta is after you retire. Right?
Yes,
like that is the time.
They're humbling.
Yeah. But, well, and every case is a little different. So no two hypervascularity scenarios look the same. The vessels that grow on the surface of the uterus in an accreta, they're different in every person. The amount of scar tissue is different in every person. How much it bulges on one way or the other is different in every person. So, and sometimes you really do have to take a different approach in each case. The major steps are standard and the principles of surgery are standard, but the order in which you may have to do things, you may have to pivot a little bit. And that comes with experience or with working with somebody more senior who can guide you through something. Mm-hmm. So that's the biggest part about training. So really instilling good habits and reinforcing them when things are easy. For example, like doing very delicate knot tying. And I joke about that with my residents because on a C-section, you can be a little more like fast and maybe less careful because it's simple and it's right there and you don't have to go deep in the pelvis. But if I use the same knot tying technique deep in the pelvis, first of all, my knot wouldn't tie down. I would tear through a big vessel, start bleeding. It won't hold. And so I really try to reinforce those good habits when it's easy. Or opening up the space behind the round ligament, the peritoneal space, the retroperitoneal space. If I can do that in a repeat C-section where maybe there's just some adhesive disease and I just need to get the bladder down, but it's not an accreta, I can show them like, this is how we do the dissection. This is how you can get around the bladder. This is where you can feel the ureter. And it's in a low stress environment. So you have a little bit more capacity to learn as the learner when it's not all high stakes all the time.
Now I want to tee you up to talk about what you've created, but I need to do that for some of our audience who may never have seen any of these surgeries. Okay.
Yes, of course.
So if you've never been able to participate in a cesarean hysterectomy for a placenta accreta or percreta, literally, sometimes there is no covering on the placenta at all. We open the abdomen, we're looking at placenta, just waiting to bleed.
Or it's like the thinnest little film.
Yeah, it's like one cell layer.
Like saran wrap.
Yes.
Yeah.
And so that's what you're having to operate in and around. So,
by the way, it's also super glued. Like if you were to put super glue on it, that's the scar tissue that you have to like get around to get to the vessels to separate it.
So trying to teach someone how to manage this delicate situation in real time is very, very dangerous.
Yes.
So now tell us what you've created, like, because it's so genius. It's just, I'm so excited for you.
Well, I can't take full credit because, first of all, simulation has been around for a long, long time. But I remember I was at home cooking a chicken for my family, and I can remember like lifting it up. You've got the little wings and you're cleaning it out, and I thought, man, this feels familiar. And
it's why I can't eat whole chicken.
It kind of looks familiar, and I realized this is about the size and the weight of a uterus with the placenta still inside. And I thought, I wonder if I can make this into a model. And some of the folks that we worked with were already doing simulation, like with chicken breast and trying to suture in utero and things like Dr. Belfort was doing this, with some of his stuff. And I thought, shoot, could I make this into a uterus? And then I thought, if I could debone this chicken and get some of the bones out of the legs and maybe the wings, I could probably make fallopian tubes. I'm like, wait a minute. And so I went straight to Julia Child from after watching Julie and Julia and the scene where she tries to debone the duck. And there's a beautiful video about Julia Child working with Chef Pepin from France, who could debone a chicken in less than a minute, by the way.
Wow.
And I was like, okay, if they can do it, I can do it. And so I figured out how to debone the thighs. And so it takes a little bit of brute force and some cooking skills. But then essentially you debone the legs. Those you take a little bit of the meat out, then it becomes very flimsy like a fallopian tube. And then I bought some 17 millimeter wide collagen sausage casings, which you can buy on Amazon just like for making sausage at home. And I wet it underwater, tie it like a balloon, fill it with water, tie the other end, and you can pass those through kind of the skin up to those legs. And that makes like the uterine vessels that go up the sides of the uterus. Is it exactly how the vessels go? No, but it functions very well. And then we, over a couple of iterations, we fill up a blue or purple glove with some water. And when you tie it, the fingers are kind of all awkward, and then it becomes a nice placenta that's extending in weird directions and different in every model. And then we can dry the surface of the skin under which that glove has been placed. Kind of like
so all this is going under the skin, between the chicken skin, just like you would separate and put the butter.
Exactly. The butter or the lemon that you're putting under the skin, you're putting a glove under the skin. And I only fill the water up to like the fingers so that when I tie it is, it's not too full. But then with a clear or a white glove, we put water and a very little splash of orange juice, tie that up, and that becomes the bladder. And I tie the fingers down too, so it looks round. And then where the tie is, it's almost like the bladder neck. We dry that off really well. And you use super glue and a bunch of super glue, put that right on where that placenta and the skin is. You have adhesions that your learner has to try to dissect out.
Without puncturing the glove or the tubes.
And if they puncture the glove, I'll even do it on purpose. Like I'll take a needle and puncture that placental glove, and you'll see the little stream of water. And I'll just show them how sometimes if you just take the one gloved hand and with the most delicate, like you were putting it on a balloon that's leaking, you just gently hold there. And sometimes that is the most important job. You're retracting the uterus. You're holding that one little bleeder without pushing your finger into the bleeder. But I'll show them like how that gloved hand can just buy you a little time while your partner is getting the vessels down. So those blood vessels that we have put in too, because they're filled with fluid, you can use clamps on the vessels. You can cut them and then ligate them. And if the ties hold and they don't leak, that's a good solid tie. If the clamp wasn't on right or it starts leaking, you can clamp it again and you got to fix it, right? So you can have people kind of like, oh, I didn't it's bleeding, but it's not really bleeding. It's just water and it's a safe environment. I've used like a video camera just to film. And really that was more so I could show the model. But what I realized too is you can see when you have somebody who's learning, they're when they're tying, that little piece of tissue is just moving all over the place. And you're like, oh, please be more gentle. They think they're being as gentle as they can be. But when I show them, I'm like, look how much this is actually moving. And then you show them progression of their skill set. It's like, look how little this one is moving. That is what you have to do every time. And it gives the opportunity for direct feedback so that the learner can actually see what they did and try to emulate some less aggressive.
I mean, it's a really ingenious, cheap way
It is cheap.
to
Yeah.
do this. So you go out and teach this, don't you? Like, have
Yeah.
you've
Well,
taken it other places and shown them?
I did. Yeah. So we've used this. Let's see, where have I gone? Chicago, Wisconsin, San Antonio. We've done it in Houston. I'm doing it again here in Galveston in October. I've definitely done it with our residents and fellows. We've done it in Egypt. The chickens in Egypt are a little skinnier. And in fact, it was two of the Accreta surgeons who work at one of the big centers in Cairo. They're twins. They're actually twin women. And they said, we got some super glue. Will that work for adhesions? I said, I don't know. And sure enough, we tried it and it worked. And so that, like, it's gone through iterations and people have given suggestions. I've started putting round ligaments in with like a crafting cord that's a 1/4 inch thick so that you have a little bit more of an anatomical realism and reference.
Next is
To
ureters.
help dissect. Oh, and I use a silicone straw for ureterolysis.
There
So
you go.
they go down through the side of the uterus and we open up that space and they have to identify and sling the ureter. So,
People think that, like, we teach this kind of stuff all the time, that you don't have to pay thousands and thousands of dollars for a fancy mannequin that talks and blinks and sweats and all of those things. Low fidelity, although this sounds pretty high fidelity, low fidelity will just as often get you the same results. It's the muscle memory in the practice. But for
Yes.
this, I find very fascinating because trying to recreate the delicacy of it in a safe way is really, that's really impressive. And I love how creative it is.
Well,
Yeah.
and the thing, I mean, I went through a lot of iterations as I started this. I have another colleague in Colombia who has a beautiful cloth model to teach the technique for focal resection and repair, where you just cut out the diseased area of the uterus and then repair it, which works really, really well for the right patients. They have to be highly selected and you have to have the team that's ready to help you do it, you know, and you have to be able to, and you have to be ready to convert to hysterectomy if it's not
Right.
working. That's so important.
So this is probably a good time to switch to talk a little bit from the patient perspective.
Well, yeah.
Is that, did I cut you off? Did you want to make another point?
Well, I did have one more thought. I mean, this model really went through a lot of iterations because cloth is great for steps, but it doesn't have the tactile feel.
Yes.
And a lot of people cringe when they hear, oh, it's a chicken and it's meat, but you have to wear gloves. You don't want to contaminate yourself with raw chicken. We're using dedicated simulation equipment that we sterilize with bleach and clean it very well. But you can cut it, you can clamp it, you can suture it, you can cauterize it, unlike something like a silicone model. And it is biodegradable. Like 90% of this model is either reusable or biodegradable. And so we're reducing plastic waste that we would otherwise throw away if we were using some super fancy model that has replaceable parts.
Yeah. And it's much more affordable.
Fabulous.
So let's talk about the patient perspective of this, because I think, it can get real easy to just get real technical. The uterus has to come out. There's no other options. Be glad that's all that has to happen. We as a healthcare community, I think we're getting better at it, but I think historically we've been rather, I don't know if dismissive is the right word, but maybe not paid as much attention as we should to the patient perspective of the significance of this. Suzanne, what's your thoughts on that?
Oh, absolutely. And I've learned so much from like Kaylee Summers, who is the birth trauma mama and has done so much work in this space. And I've learned so much from her and listening to her. And yeah, maybe dismissive is not the right word, but just even some of the things that I've said in the past or I've heard said to patients that were going through a difficult delivery or some kind of this is trauma. This is traumatic to get the diagnosis, to go through the surgery, to go through the postpartum period. I mean, wha- it's trauma and we need to recognize that. And I do think we're doing a better job. And I know that there are some programs for patients like this, but I'd like to hear what you're having to say, what y'all are doing with that side of the human side of placenta accreta spectrum disorder.
Yeah. And it's so challenging. And a lot of us still wrestle with this. I mean, we've already kind of touched on the fact that we're really good at it. Now we are learning that we have to diagnose it early. We're really trying to get people to the right center and have those referrals. And we're really good in the operating room. And then people are postpartum and it's kind of like, great, you're done.
You lived.
Graduated. Yeah. And so, but this is not something that people just are ready to recover from. I mean, really, the best analogy I have without having solid data is that just like having a heart attack or a cancer diagnosis can impact mental health and well-being, it's a life-changing diagnosis in more ways than one. Even just hearing, I have Accreta, it might be life-threatening. There are women who have written letters to their children in case they don't wake up.
Mm-hmm.
And they might do fine. I had one patient tell me, like, well, shoot, there was all this drama beforehand because of how serious this was, and I feel fine. And so she kind of felt like a letdown. Like, I thought it was supposed to be more dramatic. But there's plenty of women too. I mean, when we think about it, if we're saying you need a hysterectomy or you might need a hysterectomy, that is a loss of fertility. It is permanent. It is, especially if we're saying we're doing a big vertical incision, which we've historically done. A lot of us now do a larger low transverse incision, again, in the right patients, not in all patients. But so it can be disfiguring to some people. Like, there's some women who feel like their bodies are never the same, just like having a breast removed with breast cancer. So, and in some cultures, loss of fertility means loss of womanhood and status in their community.
Mm-hmm.
I've had some patients say, you can tell my family that I had a C-section, but you must not tell them I've had a hysterectomy or I will be shunned.
That's
and
horrible.
Can you imagine? And can you imagine? So, I think it's really profound. And so that's why a lot of us, there is a shift, to say, like, it has to be a hysterectomy at all times. We have gotten much more savvy in our knowledge about this disease process. And a lot of this is from work that's been done in South America, in Indonesia, in France, looking at when can we preserve the uterus. The French data, they leave the placenta in place a lot. It can resorb, but the only concern I have about that data, and they are stating this in their writing now, is that not everybody's a candidate. So if they're bleeding, they might still need a hysterectomy. But for those for whom it's successful, it works. So there's a proportion of patients who might be able to leave the placenta in place. And over several weeks or months, the placenta may come out, and then later they can get pregnant again.
I want to hop on that real quick for our listeners.
Yeah.
So this is an individualized decision made by experts in an expert center, because leaving the placenta in significantly increases the risk of hemorrhage, infection, sepsis, septic shock, ICU admissions, and ultimately loss of fertility in an even more, potentially more complicated surgery. So it is I agree with you. I'm seeing more and more conversation in the US about where is this appropriate? It's less black and white. You must have a hysterectomy under all scenarios in all situations. But again, this is a highly individualized expert conversation.
Yes. And it has to be very nuanced. You cannot, and it never would, I don't know a single expert on the planet who would ever promise a woman that she will not have a hysterectomy.
Right.
Ever. Because the default is always hysterectomy.
Right.
Yeah. And the trade-off also is, if we're starting to do only leaving the placenta in place, what they're seeing in France, and talking to some colleagues who do not like this approach in France, is that people are losing their skill set for how to do the surgery. And then when you do have that emergency, then what do you do?
Yeah.
And because the treatment, it can go on for a few weeks, then people are home when they have the emergency, it becomes a little bit more difficult. We've also learned, like, from the folks who do a surgical preservation technique, and that's a big if, by experts looking at the time of antenatal imaging, and you have to also look at the time of delivery at surgery, you can get the bladder down enough safely. Maybe you're tying off all those big vessels that grow and look ugly, and the scar tissue is not so bad that you can't get around it. And there's enough healthy tissue on the lower part underneath that area that's involved. You can, make your incision above that placenta area, deliver the baby, cut out the affected area. You have to do some stitches to help stop blood flow from the vagina.
It's complicated. It's complicated. And so it takes an expert to know what they're doing.
Nuanced.
Yeah.
Yeah. But then they can repair the uterus. And the whole goal with both of those techniques, the primary goal is not to do more surgery that's then going to cause an injury, like a bladder injury or a ureteral injury, if it's not necessary. The primary goal is not future fertility. That it happens, and they've shown that it can be the case. But every expert who does these kinds of procedures always says they started small, and they're always careful that if they cannot get that bladder down, if it is not safe, you must be prepared to proceed with hysterectomy. You abandon the attempt to get stuff down, and you deliver the baby first.
So how has this impacted you? Like these are
Oh
emotional
gosh,
cases. There's
they are.
cases. It's
Yeah,
patients, families,
patients.
right?
Yeah.
I
Yeah.
Yeah,
Talk
I will
about
tell
that.
you, there are a couple of patients who still contact me to this day and who are involved in the patient coordination group. Thankfully, I mean, and they've had, watching their journey has been really amazing and thought provoking for me. It's challenging. It is very hard when here's the thing. It's hard for me as a provider, especially when things don't go as planned, especially if we have a bad outcome or an injury. Like that's not what we got into medicine to do. Um, it is infinitely harder for the patient and her family, though. So, as hard as it may be for me, yes, it is hard, and um, that's why I do the things I do sometimes. Like I really focus on family. I really try to maintain, a connection spiritually in a meaningful way. I exercise. I really do try to focus on some self care because I know that I have to be sharp and I have to be there for these patients because really, as hard as it can be on me as a provider, it's even harder for them. Um, but it does take a toll sometimes. Like there are definitely patients who I may never see again in my life that I will never forget, or family members who I may never run across in my life, but I can feel their hug. I can feel their tears. It's one of those things where you do not leave that OR without remembering something physically at a physical level. Um, And it's hard too because like these cases are long sometimes, like,
Yes.
Yes.
on average, maybe 3 or 4 hours. For a decent case, they have gone as long as 13 cases. I have had to do 3 cases in a 24-hour period, and that's
Wow.
a lot.
Brutal. That's
It's yeah,
physically
like that's
I
demanding.
can't
you
even.
can't do that every single day of your life. That's why, again, having big teams, having backup support,
Yes.
really being mindful about when you schedule and how you schedule and have contingency planning, even at the referral center, not just in the smaller community hospitals. You need to have that backup and work on systems. So that's part of it. And then watching the journey of patients who have gone through this transition though, and really trying to listen and also learning to listen to what they value.
Mm.
Even if I have to say, oh, and I'll give you an example without naming names. And she's already been on a podcast and told her story before, but I'm not going to name names. But I've had a patient who had many, many babies, had been a surrogate, who needed a hysterectomy for a very extensive placenta accreta spectrum. And she confided in me. She said, all of my adult life, I have either been pregnant or birthing babies, and I'm really good at it. I don't know who I'm going to be when this happens. It was a huge
Interesting.
identity shift.
Mm-hmm.
And I said, that's really honest and I appreciate that. And the other thing is too, I have to accept that, especially at that time, I didn't know how to do the focal resection and repair technique. And thinking back on her case, she would not have been a good candidate for that. Like
Mm-hmm.
her placenta was too extensive. But I didn't have that tool. So that's part of the growth of patients telling those stories and learning from other people who are doing work elsewhere is so important to make me a better, more well-rounded surgeon, clinician, person, human being, and advocate for these patients. Another example is another patient who said, I don't care if you take my uterus out, just whatever you do, I have to get back to my son and for this baby. Like, I don't care what you have to do, just keep me alive.
Mm.
So hearing, like really listening to what this individual values most is so important. And while many people still value their life, when it really comes down to it, when we have those conversations, that's number one. But there are people who will tell you clues. I am going to struggle if I have a big vertical incision. I am going to struggle. Or, for example, I take care of a lot of patients who refuse blood for religious or other reasons,
Mm-hmm.
Yeah.
who also have accreta.
Mm-hmm.
And that's kind of scary to a team if we can't
Yes.
transfuse when there's a big blood loss.
Yeah.
But guess what? To those patients, many of them say, I had a wonderful patient tell me, if I get that transfusion, I will forever be separated from my family in heaven after death.
And that's a whole nother conversation.
We have a lot of conversation. That's another podcast.
But yeah,
you have to listen to what
you
is really
absolutely have to
valued by these
listen.
patients. Like it's a different story if I can hear that and I can plan how am I going to try to do this differently so we don't have to transfuse.
So what do you want as we kind of wrap up here, because we've been I mean, there's so much to talk about.
Yeah,
I know.
We talk all day long.
I'm just fascinated just listening to all of this. I mean, from the chickens to the news, to new things that you're doing, to the patient perspective. It's just amazing, Karin. I mean, I'm so impressed.
Well, I think the take-home messages that I would leave people with is just like you said, have a plan.
Yes.
Know your friends and who to refer to, especially in an emergency, or even if you can't send the patient, who you can call for help.
Mm-hmm.
Is if there's even somebody who can walk you through some steps if you're really in the fire of things, because this happens.
Mm-hmm.
Or knowing who to go to for moral support after. Like, you need a debrief, not just for you, but for your entire team, for the family, for the hospital. It's just good practice.
Yeah.
To do the technical debrief and the emotional debrief. I think they're two separate but very important aspects. And continue to learn. Like, I think it's so important to recognize that, again, like I said, you are never going to, we joke about, we say we're experts at XYZ, but I'm not going to be an expert in Accreta until the day I stop operating.
And I think that's what really sets you apart from a lot of people, a lot of physicians, just not even in the Accreta space, just in general, because you are clearly highly specialized, highly expert in this, but you're very humble and you understand your limitations and where other people can continue to contribute to your growth. And I think that's a lesson for all of us to learn, that it doesn't matter how good we get at something, there's always somebody else who has something else to offer that can contribute to our growth in one way or another. And I think that's beautiful to model, really, truly. Thank you for that.
There's always going to be that case too, that like, I can think I've seen it all and then, nope, haven't seen that one before. So, well, okay, let's figure this one out. Let's troubleshoot the problem. So,
because you truly don't know until you do get in there a lot of times. And we've all been in that OR, and you've got to, like you said, you've got to be nimble to go a different direction or do something different. And that's where your whole team can assist you and be prepared for those different directions.
Yeah.
Before I forget, I do think that there are some real fundamentals too, like for anybody, low resource settings, smaller community hospitals. So there are some fundamental skills that can help you manage even just postpartum hemorrhage because of atony when things are getting really severe, that are really important to know. And these are also things that can be simulated or that you can read about. Manual aortic compression. I mean, everybody has, not everybody has two hands, but most people have two hands.
Most people in a surgery that are doing surgery have two hands.
But you can, and it doesn't, like, I have, even when it's not an Accreta, for example, we had a deep extension into the lower segment just a few nights ago, and I put my hand on the aorta and I told you have to communicate with your anesthesiologist.
Right.
I'm giving some manual aortic compression until we get blood in the room. And I had my resident follow my hand down. And we have simulated this before too, just using that sausage casing, but follow my hand down. I need you to compress the aorta right here where my hand is. Slow down the bleeding just enough for me to repair that laceration.
Right.
So there's simple fundamental techniques that you can learn. And that is one of them. Also, same thing about pressure, tamponade, packing the abdomen,
right,
that go beyond just Accreta care, just any hemorrhage.
Yeah.
That are really fundamental. And for the nursing staff too, I think this is really important. The communication skills to be able to escalate.
Yes.
I can't tell you how many cases, either I've been the observer who just walks in, I'm the new set of eyes, or somebody says, it might be the nurse saying, hey, I'm seeing some blood in the bag below the legs, or there's blood that's trickling on the floor. Did you know about this?
Well, maybe we need to have another podcast to talk about other things like this. I like this. I like this direction. But so, where do you want to tell people where they can find you, or do you want them to follow you on social and tell them where to get more of Dr. Karin Fox?
Oh my goodness. Okay. Yeah, you can follow me on social, but a lot of my social posts are just, they are a lot of the things that are in the journal for which I am working. So that's great information. You can follow me at Karin karin.fox.md on Instagram. I am going to put a plug in for the Pan American Society for the Placenta Accreta Spectrum at www.pas, spell out the word squared.org. We are renovating our website as we speak and trying to create more content for both patients and providers. It's a work in progress that we do on our free time. And
I'll put all this in the show notes. I'll put all this in the show notes, and you can send all your links and everything. We'll put the show notes so people can find you when this comes out.
And I would be remiss. I'm going to put a shameless plug in for the American Journal of Obstetrics and Gynecology, simply because we did, I'm going to give all the credit to Roberto Romero, who came up with the idea to have a cesarean delivery special supplement.
Yes.
And I was just honored to be able to participate in that. We've got all kinds of manuscripts about Accreta, about complex cesarean delivery, about
we'll put a link to that in the show notes as well, so people can check it out.
Oh my gosh, please. Yeah. It's I send residents and trainees articles from there almost daily.
I loved that edition, and I appreciate that so much, because we did a whole podcast on cesarean section is major abdominal surgery, and that supported everything that we were talking about.
We don't even use the word C-section anymore. We just say major abdominal surgery. So they took the patient back for major abdominal surgery.
Yeah, exactly. Well, there's some great patient perspectives in there too that are important. So
we'll put that link in there, because that's fantastic. So
and I'm going to give a plug too to some of my colleagues who have also done a special edition for Accreta in the Green Journal, the Obstetrics and Gynecology. Also, that was edited by Brett Einerson. So please,
great. We'll put all of that in there, because I think, for anybody who wants to learn more about this or understand more, I think these are all huge resources. So, but thank you, Karin. This was really amazing. I mean, the time flew by. Like,
it did. I was like, I can't believe it's been an hour.
Go for another hour.
I know. So much information, and we just appreciate all you do for these patients and their families, and amazing. And I appreciate you even more, because you published with me on this for a couple times. I feel like I'm out of my realm now with all the new changes, but all the nurses and docs that wrote in the A1 high-risk critical care textbook, and you're always so great to write with, because you actually do so much of the chapter, and your expertise was really greatly appreciated. I think. Thank you.
Thank you.
Well, thanks for listening, everybody. Don't forget to go to our Patreon at patreon.com/CCOB and check out the diabetic ketoacidosis in pregnancy education program that we've just launched at clinicalconceptsonob.com. And we'll talk to you guys again soon.
Bye.